Okay, let's dive into this. Think about this number. Over 3 billion pounds.
Huge amount.
Yeah. Specifically, 3.073 billion for 2025-26. That's the total core funding the NHS gives to community pharmacies in the UK.
That's the overall pot, yes.
But here's the bit that really caught my eye. A massive chunk, 900 million of that, isn't just like a straightforward payment. It's linked to something called retained buying margin.
That's exactly right. And that 900 million figure, it's essentially the target profit, the collective target for all pharmacies. They're meant to achieve this by, well, buying the medicines they dispense as cleverly and cost-effectively as they can.
Right, by getting good deals.
Basically, yes. And the main lever, the main tool the NHS uses to manage whether the sector actually hits that target is a mechanism called Category M. It's part of the drug tariff.
Category M sounds a bit like, I don't know, a code name or something, doesn't it?
Hey, maybe, but it's far from secret.
Well, the sources we looked at for this deep dive from Accord and Community Pharmacy England, they make it really clear this is like fundamental to how pharmacy funding works. It came in with a contractual framework back in April 2005.
Yep, been around a while now.
So our mission today is to really unpack Category M, what it actually is, how it's supposed to work, and importantly, why it seems to cause quite a few headaches, but also opportunity for pharmacies and the NHS itself.
Yeah, it's definitely one of those complex sort of behind-the-scenes things, a vital cog in the funding machine, but maybe not something everyone fully understands.
Right. So let's start simple. What is Category M, fundamentally?
Okay, simplest terms. It's a system within the drug tariff, the official NHS price list for reimbursing pharmacies.
Got it.
And for a specific group of medicines, currently it's over 600 products. Category M is just the method they use to set the price the NHS pays the pharmacy for dispensing them.
Okay, so it sets the price for some medicines. And the aim of setting those prices is specifically to steer towards that 900 million retained margin target.
Precisely. The whole point of the Category M prices is that they're set with the idea that, averaged out across all pharmacies in England dispensing all these specific medicines, the sector should collectively make that 900 million profit. By buying the drugs for less than the price the NHS pays them back, that difference is the retained margin.
Okay. So a price-setting system for hundreds of drugs, trying to engineer this collective profit target. Wow, that sounds incredibly intricate. How on earth does the NHS actually do that? How do they set and adjust these prices?
Well, it's a quarterly process, so things can change every 3 months. The Department of Health and Social Care, the DHSC, they're the ones who set the prices.
Right.
And they use specific data to do it. They get information from drug manufacturers, how much they're selling and at what price. And they also get data from the pricing authority about dispensing volumes, basically, how many prescriptions for those specific drugs are actually being given out by pharmacies.
So they're looking at both sides, what's coming from the makers and what patients are actually getting.
Exactly. But here's a tricky part. They have to set the prices for the next quarter before it starts.
Ah, so they're guessing future use.
They're using estimated dispensing volumes, which obviously might not be spot on. So the system has this built-in correction thing. If it turns out pharmacies collectively earned way more or way less than they were supposed to be on track for that 900 million, then the Category M prices for the next quarter get tweaked, adjusted up or down to try and nudge the overall margin delivery back towards that target.
Ah, okay. So it's not just set and forget. It's this constant recalibration based on what's actually happening, trying to keep it hovering around that 900 million mark.
That's the theory, yes. And it means constant monitoring is essential. Community Pharmacy England, they represent the pharmacies, and the DHSC, they both watch this like hawks. The sources mention CPCF invests a lot of resources into analyzing it all, and they have regular meetings with the DHSC to flag issues and give feedback.
Yeah, you'd absolutely need that close watch on something so dynamic. But even with all that scrutiny, the sources we read definitely point to some big problems, practical problems with how Category M actually works out there. What's the first big challenge?
I'd say one of the most persistent ones is quite simply whether pharmacies can actually buy the products at a price that makes the Category M reimbursement work.
Meaning?
Well, the DHSC deliberately sets the Category M reimbursement price higher than the price the manufacturers originally say they're selling at. The gap is the intended margin.
Well,
But,
always a but.
hey, yeah. The problem pops up when the Category M reimbursement price gets cut. Which happens, remember, if the margin is running too high overall.
The recalibration.
Exactly. When that reimbursement price drops, it can take time sometimes quite a while, for the prices the wholesalers charge the pharmacies to catch up and fall too.
Oh.
So pharmacies get stuck. The amount the NHS will pay them back for dispensing the drug is suddenly less than, or maybe even the same as, what they have to pay their wholesaler just to get it in stock.
Wow. So they could literally be losing money on those prescriptions until the wholesale price drops. That sounds incredibly stressful for a small business pharmacy.
It's a huge challenge, a real cash flow problem, and it hits profitability hard. The sources actually say that pharmacies are basically expected to put maximum pressure on wholesalers to get those prices down.
Easy to say.
Quite. As you can imagine, that pressure doesn't always work instantly or evenly, especially when you're talking about hundreds of different medicines.
Okay, so that's problem number one. The NHS price doesn't always line up with the actual cost from the wholesaler, at least not straight away. What's the second big issue the sources flag?
The other really significant one they discuss is branded prescribing.
Right, prescribing a specific brand name drug when there's a generic version available.
Exactly that. Or sometimes it's these branded generics or off-patent brands. Now remember, the Category M prices for the generic versions include that built-in profit element, the bit contributing to the $900 million margin.
Yeah.
What can happen is, sometimes the Category M reimbursement price for the generic drug ends up being higher than the simple list price of a branded, or maybe an off-patent branded, version of the exact same drug.
Ah, I think I see where this is going. Someone, maybe in NHS commissioning, looks at the list prices side by side and thinks, hang on, the branded one looks cheaper today.
Precisely. Some clinical commissioning groups, or maybe their successors now, might encourage doctors to prescribe the branded version, thinking they're saving money on that specific script right there and then.
But the sources were pretty clear this actually messes up the whole Category M system, didn't they? How does choosing the brand cause problems?
It effectively bypasses the system's engine competition. Category M really relies on a healthy, competitive market for generic drugs.
How so?
Well, when a prescription is written generically, pharmacies are incentivized to shop around to find the best price from different manufacturers or wholesalers for that generic drug. This competition forces suppliers to keep their prices keen.
Right, driving the price down.
Exactly. And that lower purchase price eventually feeds back into the data the DHSC uses, which then allows them to set lower Category M reimbursement prices over time. That's how the system is meant to deliver long-term savings for the NHS.
Got it. So prescribing the brand name, even if it looks cheaper on paper right now, actually stops that competitive pressure. It prevents the generic price, and therefore the Category M reimbursement price, from being driven down further.
Yes, precisely. You kill the competition that would ultimately save the NHS more money overall in the long run. It prevents the system from working as intended. Plus, it can mean that the $900 million margin gets distributed unfairly across the country. Areas where they prescribe brands a lot just won't generate their share of that margin through efficient generic purchasing.
And what does Community Pharmacy England think about this practice?
The sources state their view very clearly. They are, and I quote, completely against this practice. Understandably so.
Okay, that makes sense.
Ah.
So this whole system obviously needs good, reliable data from manufacturers and wholesalers to function. How does the DHSC actually get hold of all this pricing and volume info?
Well, back when Category M started in 2005, they set up these voluntary schemes. Scheme M for the generic manufacturers, Scheme W for the wholesalers.
Voluntary, so they didn't have to provide the data.
Initially, no. They were encouraged, and it was backed by legislation, the Health Act, 1999, but it was voluntary participation. That changed, though, significantly.
How?
In July 2018, new regulations came in the Health Service Products, Provision and Disclosure of Information Regulations 2018. These basically made it mandatory. It became a legal requirement for manufacturers and wholesalers to provide the sales and volume data that the DHSC needs to set the Category M prices.
Ah, so it went from a please help us to a you must tell us approach.
Yeah.
A big shift to make sure the data pipeline was reliable.
A key change, yes,
Yeah.
needed to make the system work properly.
Right. We've covered quite a bit what Category M is, the theory behind it, the quarterly adjustments, and these big challenges like getting stock at the right price and the whole branded prescribing issue.
Wrong.
But let's just zoom out for a second. Why should you, our listener, maybe you don't run a pharmacy, maybe you don't work in NHS procurement, why should you care about this, well, seemingly quite technical pricing system?
Because it has a really direct impact on the health, the financial stability of your local community pharmacy.
Right.
That $900 million margin isn't just like extra cash. It's a core expected part of their income within that overall $3 billion funding.
It's money they rely on to operate.
Absolutely. So if Category M isn't working right, if pharmacies consistently can't achieve that margin because of pricing issues or availability problems, well, that puts huge pressure on their ability to stay open, to offer services.
And maybe even to keep the medicines you need on their shelves.
Exactly. A financially squeezed pharmacy sector affects everyone who relies on it. And it impacts the NHS overall, too. Like we talked about with branded prescribing, if practices undermine Category M, it can actually end up costing the NHS more money in the long term, money that could potentially be used elsewhere in healthcare.
And yeah, definitely, if pharmacies are struggling to buy drugs at or below the price the NHS pays them back, that could easily affect what medicines are actually available for you when you walk in with a prescription.
The smooth running of Category M is really closely linked to making sure medicines get to patients reliably. It's all interconnected.
Okay, so let's try and pull this deep dive together then. Category M is, well, it's complicated, isn't it?
Definitely complex.
But it's absolutely critical. A key, if maybe slightly obscure, piece of the funding puzzle for community pharmacies in the UK. It kicked off in 2005. Its main job is to help the entire sector hit that 900 million retained buying margin target. It does this by setting and adjusting prices every quarter for what, over 600 medicines?
That's right, based on market data.
But, as we've heard, actually making it work in the real world throws up some major hurdles. Things like the delay between NHS price cuts and wholesale price drops, and this whole issue of branded prescribing messing with the generic market competition it depends on.
Yeah, it's a system trying to use market forces for public good, but it's constantly bumping up against, well, market realities and those unintended side effects.
Which kind of leaves us with this final thought for you to ponder. We know Category M relies heavily on data from suppliers, and it's meant to incentivize pharmacies to buy smartly. So how does this constant negotiation, this dance between manufacturer prices, wholesaler charges, what pharmacies can actually buy for, and the NHS reimbursement price, how does all that ultimately shape not just pharmacy finances, but the behavior of the whole drug supply chain? And maybe most importantly, how does it affect your ability at the end of the day to get the medicines you need right when you need them? It seems like this one mechanism has ripples going out much further than you might first think.